Call this meeting to order. Welcome to meeting number 143 of the House of Commons Standing Committee on Health. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have with us here in person Dr. Aaron Knight, Associate Professor, Department of Psychiatry and Family Medicine at the University of Manitoba. And online we have Lorraine Brett, the Assistant Editor of the New Westminster Times, and Dr. Daniel Vigo, Associate Professor at the University of British Columbia. Thank you all for taking the time to appear today. As I expect you've been informed, you will have up to 5 minutes for your opening statement. And we're going to begin with you, Ms. Brett. Welcome to the committee. You have the floor.
Thank you very much for this opportunity. My name is Lorraine Brett, and I've lived in New Westminster, BC since 1994, where I've raised 3 boys with my husband, David. I'm here to address the devastating mental illness, overdose, and homelessness crisis facing this country. For the better part of 20 years, my now 40-year-old son, Jordan, lived on the streets of New Westminster and Vancouver's downtown east side as a drug-addicted, homeless, mentally ill man. It was 20 years of living hell. He survived 12 overdoses. He would be rushed to New Westminster's Royal Columbian Hospital only to be discharged to the streets a short time later. Excuse me. When addicts face death, there is often a moment of clarity. They want to stop the nightmare. I will never forget the agony of listening to my son outside of RCH emerge and hearing our son say, through tears, "I don't want to die." To get into a recovery bed in BC, you need to first go through detox, but detox typically has 2 to 3 weeks of waiting or more. And clients have to call every day, which is hard to do if you don't have a phone. Jordan overdosed and was revived twice on that wait list. There is an illusion often fostered by misleading government PR campaigns that addiction care is available for those who want it when they want it. Well, this is not true. I saw calamity erupt on the streets during COVID when the discreet access to safe supply rolled out to the homeless addicts. Like a sick sideshow circus, the endless drug use saw human beings like my son devolve to the level of animals from excess use. And worst of all, COVID reduced the number of recovery beds and detox beds and shelter beds. Such a horrifying catch-22 for the street-entrenched mentally ill are most vulnerable, helpless without anyone to champion their dignity and their intention to get off drugs. Safe supply and legalization of hard drugs creates an inferno, a deeper level of hell. It stalks, traps, and incinerates lives. Our son, well, he's doing much better. And how could this be? Well, here are some things that did not in any way help our son. Slick government marketing campaigns about ending stigma, safe supply, decriminalization, social justice activists calling to dismantle systems of oppression. Here's what did work. Involuntary treatment in locked facilities, appropriate antipsychosis medications administered in a controlled environment, psychiatrists willing to use the BC Mental Health Act to commit those suffering from psychosis and addiction, the availability of a bed in an appropriate facility. In 2006, I helped found the New Westminster Homelessness Coalition, and I spent 5 years there helping to launch a pilot project for services that are still operating today, such as wraparound services for the hardest to house. And many, many wonderful people are working on the front lines of this crisis. But I've spent enough time in this system to know the difference between an expensive and professional media relations campaign and actual results. For example, in BC, a new recovery psych psych facility called Redfish was opened on the Riverview lands. And, you know, those ribbons were cut and the government-fueled media fanfare trumpeted great progress. Unfortunately, the public is mostly unaware that Redfish was just a replacement for the aging Burnaby Mental Health and Addictions facility where our son spent 3 months. No new beds were created. Well, where are all the new beds? Thousands more are needed, not a few hundred sprinkled across the country here and there. Here's my request of you all. Stop trying to change the channel by pointlessly boosting expensive anti-stigma campaigns and safe supply rhetoric. Stigma has nothing to do with the overdose crisis. It's just a cynical PR strategy to make the public think they're causing overdose deaths through the way they think and talk about addicts. And that is nonsense. There is no such thing as safe supply. Stigma does not kill, drugs do. The myth is that if it were not for stigma, addicts would be rushing to access the care they need and safe drugs, and that's a fabrication. There is not enough care available for those who already actively seek it. Jordan, he was an innocent, happy kid a mom could be proud of, a football star, a standout all-around athlete, hardworking, focused student. Then it all went south. Alcohol led to pot, which led to crack, which led to meth, which then got mixed with fentanyl. Jordan does not want to be a drug user. He works incredibly hard to stay off drugs, and he just celebrated a year clean. Here are some concrete recommendations for you. Prioritize those simultaneously suffering from addiction and psychosis. Dramatically expand the use of mental health laws to incarcerate and treat dual diagnosis persons. Dramatically accelerate the opening of thousands of beds in secure facilities. It's an emergency. Take it on as an emergency. Find those facilities, procure the land, make the construction happen. For those who are addicted but not psychotic, but present with psychotic symptoms, like paranoia, remand them to care and voluntarily. If the psychotic behavior disappears, well, then let them off into the voluntary treatment facilities. But now, for sure, expand tenfold the number of detox beds and expand tenfold the number of treatment beds in Canada. Thank you very much for listening to me today.
Thank you, Ms. Brett. Next, Dr. Erin Knight, who's with us here in the room. She's an associate professor at the Departments of Psychiatry and Family Medicine at the University of Manitoba. Welcome to the committee, Dr. Knight. You have the floor.
Thanks very much. As mentioned, I am an associate professor in the Departments of Psychiatry and Family Medicine. I'm the medical lead of the Provincial Rapid Access to Addiction Medicine Clinics in Manitoba, and I hold several other leadership roles in addition to practicing clinical addiction medicine and family medicine. While I'm speaking today as an individual, I am also the president of the Canadian Society of Addiction Medicine, and some of my comments are drawn from CSAM's submitted brief. I will note that any response to this complex crisis will need to be multifaceted and responsive to the needs of all people who use drugs. However, my recommendations will focus on those with substance use disorder. I will begin with a story that, although fictional, is a compilation of real events. Angela is a single mother. Her partner Alex was incarcerated for drug-related charges at a time when they were both using fentanyl. Alex went through severe opioid withdrawal and was denied treatment. Angela sought help and was started on buprenorphine naloxone. She did well and was excited to move forward with her family. Sadly, Alex died of a drug poisoning a few weeks after his release due to a loss of opioid tolerance while in custody and his untreated opioid use disorder. Angela has remained stable, but at our last visit told me she needs to taper off of her medication. She feels she can better support her kids while working than she can on social assistance. However, when she starts earning income, she'll lose her medication coverage and she can't afford to pay for it. Unfortunately, her chances of long-term success are low, and I'm afraid that she will join the over 47,000 Canadians who have already died of drug poisoning since 2016, leaving her kids with both parents lost to the opioid epidemic. My first recommendation is for the federal government to support national decriminalization of drugs for personal use. While outcomes from Oregon and Vancouver pilots have been poor and have already begun to be scaled back, accompanied by escalating calls for involuntary treatment, it's important that we not discount the idea of decriminalization based on flawed policies. A key component to successful decrim, as evidenced in Portugal, is assessment and direction to treatment for people with problematic substance use. This element of dissuasion has been missing in North American efforts and must be combined with scale-up of on-demand, evidence-based treatment prior to rollout. Rather than jumping from decrim without any enticement for change all the way to implementation of involuntary treatment, we should focus on the middle ground, using well-constructed decrim policy to encourage voluntary or minimally coercive use of accessible evidence-based treatment. Had Alex been offered treatment instead of incarceration, he may be still alive today to see his kids grow. My second recommendation is for the federal government to establish a task force to develop and enact a national action plan for addressing substance-related harms. There's far too much variability in access to evidence-based care across regions, including between provinces and between urban and rural or remote locations. This is particularly evident in areas where jurisdictional issues between federally and provincially funded services lead to gaps in care, including incarcerated populations and Indigenous communities. Going back to our story, had Alex been incarcerated in Alberta instead of in Manitoba, he would likely have been offered treatment because of differences in provincial correctional policies. The third and more straightforward recommendation calls for universal coverage of medications to treat opioid use disorder, which will not only save the lives of people like Angela, but also support them to work with fewer barriers. Specifically, buprenorphine products and methadone, the first-line treatments for opioid use disorder, should be prioritized for immediate inclusion on a national pharmacare formulary, with further consideration of alternative agents. Additionally, injectable naltrexone should be prioritized for Health Canada approval and included on the pharmacare formulary once available. In conclusion, an effective response to the opioid epidemic and toxic drug crisis will be multifaceted by necessity and must include expanded support for people with substance use disorder as one component. In developing this urgent response, we also need to deliberately combat stigma and divisiveness, recognizing that people who use drugs are our family, our friends, and our community members, and they deserve care. Thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Knight. And finally, Dr. Daniel Vigo from the University of British Columbia, coming to us via video conference. Welcome to the committee, Dr. Vigo. You have the floor.
Thank you, President. The situation in which we find ourselves in Canada and in BC has been described by Ms. Brett and the previous speaker. And the question is, why? And how can we move forward improving those outcomes? The reason why we have in the past 10 years gone from, in Vancouver, in 2013, the chief of police and the mayor called a press conference declaring a mental health crisis because there were a few hundred, about 300 people with severe mental illness, polysubstance use disorders, and acquired brain injury that were displaying some of the situations that have now overwhelmed our communities. And the chief of police and the mayor were saying, health system, please take care of this. We are unable to do that. We are police officers. And so why is it that in 10 years we have gone from 300 to 10 times that and 100 times that at risk of suffering those severe illnesses? There are three main causes for that. The first one is the closure of Riverview Hospital in 2012 without replacement. The replacements should have been sufficient community services and sufficient inpatient beds to provide treatment, mostly voluntary treatment, but at times involuntary treatment as needed. The second reason was a technological revolution that happened. And as with every technological revolution, it took society by surprise. That technological revolution was the backyard production of cheap synthetic opioids at scale, with precursors that are impossible to stop, cheap to obtain, and allow anyone with entrepreneurial instincts and no ethical boundaries to transform $1,000 into $1 million by creating the tragedy that we're seeing. And that has happened in many areas of human experience where technological revolutions impact like this. The Moore's law for microchips predicted that every 2 years the potency of the computational power of chips would double. Well, morphine led to, in the hands of these entrepreneurs, led to 100 times more powerful fentanyl and to a 10,000 more powerful carfentanil. Now, when that happens, the nature is transformed by these molecules. Our brains are transformed. The ability of these drugs to produce addiction, while at the same time they damage the brain and prevent people from recovering and engaging voluntarily in treatment, has been overwhelming. And the third cause for this situation is that, as was highlighted by the previous speakers, a group of patients was particularly vulnerable. Patients with severe mental illness that are exposed systematically to these synthetic drugs. By the way, not only opiates, but also the synthetic stimulants, the crystal meth of the world, and the new combinations of every drug that now contaminate the illicit drug supply. The systematic exposure of the people with severe mental illness to these drugs generates acquired brain injury. Now, that acquired brain injury generated a new clinical triad that is now the norm in our cities. And we are unprepared for it because it didn't exist to the scale and to the severity and complexity that we're seeing. I'm a psychiatrist in an assertive community treatment team. We are interdisciplinary teams that treat these patients in the community, finding them where they are, homeless, finding them housing, finding them the adequate inpatient bed when they need it, the ED visits just for the time they need it, giving them involuntary care when they are unable to seek it out themselves, putting them out of involuntary care the minute that they are able to regain their ability to engage and the mental impairment is treated by the adequate combination of psychiatric medication and OAT. So these three things have created a blind spot in most of our societies, in most of our communities. Now, how do we fix this? Since June of this year, I'm the Chief Scientific Advisor for Psychiatry, Toxic Drugs, and Concurrent Disorders, and based on a decision to develop and implement evidence-based policy, we have access to all the data provincially. We know the number of beds and FTEs, psychiatrists, GPs, nurses, social workers that are needed. And our recommendations have to do with many of the things that have been said by the two speakers before, which there's a thread of agreement in our three testimonies that I would like to highlight. We need streamlined access to life-saving pharmaceuticals, including the ones that were mentioned right before me, like depot naltrexone and naloxone, but also simplifying the use of clozapine, which is a life-saving drug for these patients, and there's a lot of red tape around its use.
Dr. Vigo, can I ask you to wind up? You'll have lots of opportunity to expand on your thoughts in the question and answer period, but if you could just bring it to a conclusion, that'd be appreciated. Thank you.
So the conclusion is that in order to improve the outcomes for this crisis, we need to expand community services and inpatient services that are able to provide both voluntary and involuntary services as needed. And we need to transform the existing services so that they are able to provide treatment for severe mental illness, substance use disorders, and acquired brain injury.
Thank you, Dr. Vigo. We will now begin with rounds of questions, starting with the Conservatives. Ms. Goodridge for 6 minutes, please.
Thank you. I'm going to start out, Dr. Vigo. Police buy-in was a key aspect of the government's justification of launching the decriminalization pilot that made hard drugs legal in British Columbia. Last week, both the BC Association of Chiefs of Police and the Canadian Association of Chiefs of Police pulled their support. They cited a continued high rate of overdose deaths, public drug use, and drug-related crime since the pilot had started. Have you or will you advise the government to end the failed experiment?
Thank you, Ms. Goodrich. The recommendations that I have provided are aligned with what we are doing now in BC, which is that the use of drugs itself should never be criminalized. However, in our societies, we have rules and regulations that should be respected by every citizen. And in that context, the current situation is that drugs are not criminalized, but the rest of the rules that regulate our interactions are enforced.
Okay, so you will not give recommendation to roll back this irresponsible pilot project?
So, coming back to my expertise, which is psychiatry, mental health, and public health, what I can say is that drug users should not be criminalized, and the laws that regulate the public space.
All right, thank you.
The safety.
I have very limited time. I'm going to switch courses.
We have limited time, but I'm a witness.
I gave you the same amount of time as I asked the question, which is the procedure here in this committee. To Ms. Brett, thank you so much for coming here and sharing your son's journey and your experience as a mother. Do you think the NDP Liberals have normalized drug use in this country?
Yes, I do.
We had a mother from Ottawa come and testify at this committee that government is acting like a drug lord. Do you agree?
In essence, it's true. I saw her testimony. Yes, it's coming from the top down. The federal government has arranged laws to support safe supply, which has been delivered to clients who divert, and young children are dying as a result. It's drug trafficking.
So, in your opinion, do you think that this dangerous pilot project that was inflicted on British Columbia should continue?
Absolutely not. The moment that one child is impacted, in any negative way, this should have been stopped. This is, a lot of the folks who come to this panel have used the word dignity and respect, but I claim that there is a moral and ethical obligation on the part of the government to respect human life and that of innocence. The children who find themselves intercepting with diverted drugs is the beginning of the end. It must come to an end.
No, I really appreciate this. And I think this is the scary part, is the government keeps hearing evidence and evidence they don't like. And so they decide that it's not actually evidence and that they're going to continue on their path because clearly we just haven't done it properly. Dr. Knight, I found it really interesting. You said that the outcomes are poor in Oregon and British Columbia, but you think that we should continue trying to do what has been a failed experiment. But then further in your statement, you actually stated that Alberta, which is doing some dramatically different recovery-oriented system of care changes, that the Alberta model, the potential person that you were fabricated in your story, that would be a better outcome. So how can both things be true? I'm very confused.
So I think intentionally or unintentionally, you've taken my comments out of context. The thing that I compared between Alberta and Manitoba is a difference in provincial correctional policy related to opioid agonist therapy. I did not speak specifically about Alberta's model of care.
Okay, thanks. So you support Alberta's use of opiate agonist therapies. I'm sure you're aware Alberta has a very innovative program that's the virtual opioid dependency program that allows 24/7 access to opiate agonist therapies. Is that something that you think we should be rolling out across the country?
I think there are elements of the VODP program that are very successful. I think that there are also elements that don't reach at-risk populations, and that it is one thing as part of a multifaceted expansion of service that we could look at. I do have concerns that it is entirely virtual, and there is some need to see people in person and to develop relationships with people. Really
quickly, you mentioned one of the things that I think is a failure from Health Canada on the lack of listing of injectable naltrexone. I have advocated to ministers of health and ministers of mental health and addiction on this particular issue, and it's fallen on deaf ears. So you now have a platform. Why do you think this is important?
It's important to expand the availability of evidence-based treatment options. Right now we have accessible our first-line treatment options. We have also in certain areas.
Specifically naltrexone, because this is something that is not available currently.
It's something that is not available currently, and that we as addiction physicians have been advocating for availability for many years. There are some barriers that have been put in place through Health Canada, and we are asking for support of the federal government to decrease those barriers so that we can have this option for treatment.
Thank you, Dr. Knight. Thank you, Ms. Goodridge. Next, Dr. Pawlowski, please, for 6 minutes.
Dr. Vigo, I'm pleased to see you all here, but I'm addressing my questions to Dr. Vigo. I think some of them were your remarks. I'm not sure if they're only your remarks, but I understand you're the Chief Scientific Advisor for Psychiatry and Toxic Drugs in BC. And certainly within the popular press, the message came out that BC was contemplating more involuntary treatment of patients in British Columbia. I wonder if you could explain your ideas about involuntary treatment, and my understanding is, and this is for a population of, you've already talked about the triad, people who have substance abuse disorder, mental health issues, and acquired brain injury all together. And certainly I think, and my understanding I think is, under present psychiatric law, there is the ability to involuntarily admit and treat people and require long-term antipsychotics. Is that what you were contemplating using more in BC? And then I think the other component of that was, I think there was something about clarifying the issue of being able to use oat, like Supplicate, in people who were being also receiving long-term antipsychotics. So maybe if you just clarify for us the whole issue of involuntary treatment and who should get it and whether that should be expanded.
Right. Thanks for that question, MP Pawlowski. For any physician, the need to provide involuntary treatment is something that we encounter with relative frequency, not only in the areas of mental health.
Dr. Vigo, we're having trouble hearing you. Is it possible that you moved your mic since your last intervention?
Can you hear me now? Can you hear me now?
I think that's I think that's better.
Okay.
Can you raise it up, just to raise the mic just up between your nose and upper lip, please?
Here?
Yeah.
Okay. Thank you very much. So we encounter people that we need to provide involuntary care to in several situations. I was an ED physician for a couple of years, and if you have someone who has suffered a concussion with loss of consciousness, and you are assessing them and you see that they're confused and they say, no, I want to go home and go sleep it off, you cannot allow that to happen. And that can happen through a different act than the Mental Health Act, but it is the same type of situation. If we go closer to home and you have a patient with a manic episode, that tells you that they want to go get on a plane and go to Vegas and so on and so forth, and you see that they are in an episode of psychosis and agitation, again, you cannot let them go as they will. You need to treat them because there is treatment for that. Now, very similarly, we know that in this clinical triad, the effect of synthetic opiates on the brain decrease the volume of the brain. They generate, the more that the brain is damaged, the higher the risk of overdose. So there's a vicious circle there that eventually leads to neurocognitive disorder, not unlike the one we see due to vascular disease or to other forms of dementia. So the Mental Health Act that we have in BC allows us and even requires us to treat people when they have a state of mental impairment meeting certain stringent criteria. That state of mental impairment is something that we find very frequently with people who are acutely affected either by the combination of a severe mental illness, a substance use disorder, or a neurocognitive disorder, the product of acquired brain injury. Now, does that mean that we want to expand the use of involuntary care? No. We want to increase the options for voluntary care, which have not been sufficiently expanded so far. And as we expand options for voluntary care, we will be able to use involuntary care more precisely to the people who really need it. In order to do that, we need to create some services that don't exist. Among them, again, under the Mental Health Act, we are able to create things called approved homes. Approved homes are a house, a secure house in the community where people at the most severe end of the spectrum that require services under the Mental Health Act for long periods of time can be housed in a safe, humane environment with one-on-one rehabilitation. And similarly to what was said by Professor Knight, we are also creating units in correctional centers. On remand in Surrey, for example, where our patients frequently wind up because of their disturbed behavior due to this clinical triad, but because of the Mental Health Act, they cannot receive involuntary care while they are being incarcerated. So what happens is that they are put in seclusion until a bed frees up in a forensic hospital. We have now created a unit, a mental health unit in corrections where they can receive treatment the moment they need it. And it will take a few months to create it, but it has been decided. So this is the type of things that we're trying to do. We're trying to allow for the treatment of people who absolutely need involuntary care, create services that can provide both voluntary and involuntary care as needed so that the overall use of the Mental Health Act will decrease, but the folks who need it and don't receive care will decrease because they will receive it the moment they need it. And you pointed out the important thing about the use of buprenorphine and other psychopharmacology under the Mental Health Act. There's no restriction under the Mental Health Act of BC as to what a psychiatrist needs to decide is the appropriate combination of pharmacology for a person who needs it. We need to provide holistic psychiatric care, and that very frequently includes, in these types of patients, a depot antipsychotic or clozapine and depot buprenorphine because of the repercussions that psychosis has on behavior if it's only treated with antipsychotics.
Thank you, Dr. Vigo. Thank you, Dr. Pawlowski. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
Mr. Thériault, 6 minutes. Thank you, Chair. Thank you to our witnesses. This is a complex crisis. Most witnesses who've come to speak with us talk about multiple solutions. Dr. Knight, you said at the outset that it takes multimodal responses. Could you quickly tell us what role stigma plays in the addiction and addiction treatment process? There is a social aspect to it, but there's also a psychological aspect to it. And Ms. Brett did not talk about the psychological aspect.
Thank you for your question. I think stigma does play a role in accessibility to treatment and people's willingness to address treatment. I think it does play a role in the way that we talk about substance use in the community, and it also plays a role within our healthcare setting. The reality is that addiction medicine is a relatively new specialty, and that incorporating substance use disorder treatment within the healthcare setting is relatively new. Even amongst healthcare providers, nurses, doctors, and other providers within both the hospital settings and in the communities, there's a need for increased education and increased competency to work with people who use drugs. And as we can build that competency and continue to work on the issues of stigma through appropriate use of language and through appropriate appropriate and person-centered approaches to people who use drugs, we can increase their comfort level with seeking care when they're ready to do that.
Dr. Vogel, est-ce que
Is there any chance that someone could assist me? My translation is not working.
il faut qu'elle pèse sur le bon piton là.
She has to put herself on the right channel, click the right button.
Okay. So do you see on the bottom of your screen where you have three options, English, French, or floor?
It's like a little globe.
Yeah, it's a little globe, yeah.
I'm trying to help her.
Okay, so if you
Yeah, I do.
so if you set that at English, then that's what you'll hear in your headset. Okay, maintenant je parle en français. Est-ce que
I'm now speaking French. Can you hear the English? Are you hearing the English? Great.
Have that option or don't see that?
Okay, on the bottom of your screen you don't see a globe, Dr. Vigo?
Nope. The globe?
There's a circle with three dots.
Uh,
It says more.
okay.
Oh, the three dots. Oh, yeah.
Three dots.
Interpretation and... Okay, thank you very much.
Okay,
Now it is. Thanks.
Monsieur Thériault, il vous reste.
Mr. Thériault, you have 3.5 minutes. Thank you, Chair. In your experience, Doctor, what is the impact of stigma in the healing process when the patient takes in the way other people are looking at them? Isn't there a process that really slows down the healing process because the stigma is internalized?
Okay.
C'est le président.
Dr. Vigo?
Je perds du temps.
Oh, for me?
That was for you.
Vigo,
Was that for
Vigo.
me?
Excusez-moi.
Okay. Merci. I think the issue of stigma is important. As you pointed out, there is self-stigma, there's structural stigma, there's stigma in societies. So I believe we are all tending to a more inclusive approach that seeks to make sure that stigma doesn't play a role in preventing people to get care, from getting care. So I think it's an important part of that. I also think that, as was said before by other witnesses, the urgent issue is the effect of toxic drugs on brains, and so most of our attention and funding should be directed to expanding available services.
La stigmatisation ne conduit-elle pas à une...
Doesn't stigma lead to underestimating oneself, feeling less good about oneself? And that leads to an inability to look at yourself in the mirror with a positive self-image? And could that not hinder the healing process or the treatment process?
For sure. That is a key piece of the treatment and the recovery journey of people who are struggling with addiction and mental health issues. And that is why it is so important that the treatment of people affected by this is holistic and includes not only the provision of psychopharmacology, but also of psychotherapy.
Donc, la stigmatisation.
So stigma is not just a political tool used by people who want more liberalization in the fight against toxic drugs.
Stigma is a concept and a societal phenomenon. Whether it's used for one thing or another, it's whoever uses its responsibility. But it is in fact something that, as you outlined, can hinder people getting care for themselves. It's something that in certain quarters can exclude people from care. And certainly every health system that I know of is trying to make sure, A, that health systems do not stigmatize people who use drugs or who have mental illness, and B, that people who have the self-stigma that you indicate can recover through psychotherapy and through various forms of interventions that allow for overcoming that.
Thank you, Dr. Vigo. Merci, Mr. Thériault. Next, Mr. Johns, please, for 6 minutes.
Well, thank you, Mr. Chair, and I want to thank the witnesses for their important testimony, especially Ms. Brett for having the courage to share her lived experience as a mother with a child that's struggling with substance use disorder. I'm going to start with Dr. Knight. Dr. Knight, can you talk about what are the risks and potential harms of involuntary treatment?
Thank you for your question. It's somewhat challenging to talk about the evidence base for involuntary treatment because the research and the evidence is very poor on all sides. There are some studies that show that involuntary treatment is helpful. There are some that show that it's harmful, and there's some that show that it doesn't really change anything. And so it's already been said by some of our other witnesses today that the use of involuntary treatment already exists through our mental health acts and can exist for people who have such severe disorders, both mental health disorders and substance use disorders, that they require care because of the lack of capacity to make decisions for themselves. However, whenever we're removing somebody's autonomy, we have to do so very carefully. Autonomy is a core component of medical care and of medical ethics, and so we need to be deliberate about ensuring that if we are removing somebody's autonomy, it is because they require it, and additionally, we need to be cautious that we are not expanding involuntary treatment at the detriment of voluntary treatment for people who want to access service.
Can you speak about how involuntary treatment, in terms of being culturally safe for Indigenous people and patients, and maybe is there concerns that involuntary treatment of Indigenous patients could compound intergenerational trauma arising from residential schools and colonization?
It's a great question. I would say that in my experience, and to sort of clarify my experience, I trained in a family medicine program specific to serving the Indigenous populations, and my family practice is specifically serving urban Indigenous populations in Winnipeg. And so one of the things that I see in my patients is that even voluntary admission to hospital is sometimes perpetuating intergenerational trauma for a variety of reasons. Any institution where people have less power over their decisions has the risk of re-perpetuating trauma. And that would only be escalated in the context of involuntary treatment. I have had patients express to me their concerns about being involuntarily admitted under the Mental Health Act and how that has perpetuated trauma. And at the same time, sometimes it's necessary. And so it is important that when we look at involuntary treatment to any degree, including that sort of coercive involuntary assessment that should be part of a decriminalization policy, we need to do so in a way that is informed by people who use drugs, and that is informed by people who are Indigenous and by minority groups that may be at higher risk of harms related to those policies.
I think that there's going to be a lot of questions more from that. Now, in 2023, the Canadian Society of Addiction Medicine published the results of a systemic review of involuntary treatment, which concluded that more research is needed to inform policy in this area. Again, Dr. Knight, can you speak about how more research can be conducted ethically on the effectiveness of involuntary treatment given the risks?
So I don't think we have time to really talk about the ethics involved and the process involved in developing a research study. Certainly anything that is researched from a health lens, particularly with vulnerable populations, which include people who use drugs and people with substance use disorders, has high levels of degree of scrutiny for acceptability. One of the issues that we pointed out in that paper that you reference is that there is such poor description of what was included in involuntary treatment studies that we can't even pull reasonable learnings from most of the studies because they don't tell us what they did other than putting people in a place where they didn't want to be. And so anything that looks at involuntary treatment and attempts to study involuntary treatment in a more robust and more evidence-based way and scientific way needs to look at implementation of evidence-based treatment as part of that involuntary treatment so that we can see whether or not outcomes are favorable.
Thank you, Mr. Johns. Next, Mr. Moore, please, for 5 minutes.
Okay, thank you, Mr. Chair, and thank you to all the witnesses who have appeared. Ms. Brett, thank you for your personal testimony here today, as well as sharing the story of your son, Jordan, and very happy to hear about his 1 year of sobriety, and you certainly have added value to the meeting we're having here today. Unfortunately, we now have a number of years data to go back on, and we see that what's the current approach is simply a proven failure. It's not working. In 2016, Canada had about 7 overdose deaths per day, which is a terrible stat, except when you compare it to now that stat exceeding 21 per day, or an over tripling of the number of deaths. So we look at, okay, what actions have taken place, and one of those actions that this government brought in was it was in a bill called Bill C-5, and what it did, it eliminated mandatory jail time for serious criminals who were producing and importing drugs like fentanyl, meth, cocaine, etc. The most serious, or what is called Schedule I drugs in Canada, what it allows these individuals to do is to import those drugs, export those drugs or produce those drugs, such as running a meth lab out of their own home. But then if they are caught by the police and charged and then sentenced, they can serve their sentence from the comfort of their own home. And I think that sends a terrible message to Canadians and allows for the re-victimization of the most vulnerable. But I want to get your thoughts on that. In your opinion, should those that are bringing deadly drugs like fentanyl and meth into Canadian communities face more serious consequences?
Absolutely. It's shocking how vulnerable, homeless, mentally ill, and addicted people are. My son was, the constant victim of violence. He was never safe. And the great irony of the baffle gab and the buzzwords like harm reduction is that while he was out on the street, decades worth of living outside, he was predated by other addicts, by dealers. He had a knife held to his throat for a $2 drug debt. He was routinely threatened. Someone in my presence said to my son, we'd break your legs for that. I mean, what? So we need to support police. We need to give them all the tools that they can, and Bill C-5 should be repealed. We need drug dealers, drug creators to face the stiffest penalties. Our children are dying, and they're dying under horrific circumstances, predated upon.
Thank you for that. You said something that I took note of. You said stigma does not kill, but drugs do. And there's certainly no doubt that that drugs are taking the lives of so many. And it is an epidemic, and that's why we're having these meetings now. We're looking for solutions. You've been very critical of the buzzwords, and you are saying we need to focus on things that actually work, actual results. Can you expand a bit on your statement about that it's not the stigma, but that it's the drugs that are taking innocent lives?
Sure. My son was in treatment 26 times. He entered 26 different treatment facilities, and in almost every case, he was kicked out. He had an undiagnosed mental illness, and this was some of the evidence. He also attended about 5,000 AA and NA meetings while he was drunk, while he was high, while he was sober. He has always had an intention to not use drugs, and yet we claim that the stigma is so overwhelming that these people need the succor of drug injection sites and safety. And this is a man who knew his mind when it came to drug use. He did not want to be and does not wish to be a user. And Safe Supply is an expensive PR campaign to promote a false narrative that these are individuals who want and need to sustain their drug use. He wanted off, and he has arrived at that moment. He is a year clean, and this is evidence that involuntary care and clozapine in combination do miracles.
Thank you, Ms. Brett. Thank you, Mr. Moore. Next, Dr. Hanley, please, for 5 minutes.
Thank you. Thank you to all the witnesses. Dr. Knight, I'll start with you. You mentioned, I think, that you trained in BC. Now you work in Manitoba. And you did point out differing approaches in different jurisdictions. For example, the availability of treatment while incarcerated in Alberta versus Manitoba. So when you look at these differing approaches across the provinces, and while you mentioned in your testimony the need or the recommendation to constitute or perhaps reconstitute the expert panel, I wonder if you can just connect those two. And are you referring to kind of reconstituting what we had in 2021, the expert panel, or is it some other vision that you have of how we can get some national leadership to help guide best practices from one jurisdiction to another?
Yeah, thank you for the question. So this is a recommendation that I highlighted that was in our Canadian Society of Addiction Medicine brief around expanding on the work done by the mental health and substance use health, expanding and reestablishing a task force to work on mental health and substance use health, specifically around addressing some of the expert advice and developing a framework that establishes expectations around availability of evidence-based care. The reality is that people who live, so you can look at it from a provincial lens. I can say the people who live near my rapid access to addiction medicine clinics in Winnipeg have vastly different access to evidence-based treatment than people who live in Red Sucker Lake, Manitoba, or in any of our fly-in remote communities that have very little access to care. Same thing is true if you look across different provinces and different jurisdictions. And so there needs to be some expectation of availability of service for all Canadians, regardless of where they live.
Thank you very much. Dr. Vigo, you started to describe the difference between criminalizing the act of taking drugs versus criminalizing or making illegal other services. I was quite interested in this, and I'm not sure you had time to finish your thoughts earlier, but can you comment on the current climate in BC and where we find the right political environment in order to ensure access to treatment and services for those struggling with addiction? In other words, that balance of what should be under the criminal envelope and what shouldn't be. How do we get that right?
Thank you very much, MP Henley. I think it is really important to strike a balance there, and I think the most accurate depiction of that is a curve developed by the Health Officer Council here in BC, later taken up by, for example, the Canada Drug Policy Coalition and others, in which when you criminalize substances, you have a high degree of harms, both at the personal level and the community level, that stem from all sorts of epiphenomena of the black markets and of all of those things, and people getting caught into the criminal system when they are using drugs or have an addiction, etc. Then, on the other hand, when you completely forego any regulations and you unleash for-profit criminals to prey on people with an addiction, you have, again, all sorts of high societal harms. So the sweet spot is somewhere in between, which is called a public health regulation approach, where you don't criminalize an illness. Addiction and mental health, mental disorders and acquired brain injury are, of course, illnesses that should be treated. But at the same time, the societies, the communities in which we live, require that the laws are respected by everyone, right? And so there isn't a contradiction between making care available as needed and demanding and enforcing respect for those rules of interaction between individuals. And I believe that is exactly the sweet spot we need to continue aspiring to, where people use drugs are not criminalized for that, but that other actions that are defined as criminal by our criminal code are enforced and receive the societal approach that we reserve for them. Does that answer the question?
Thank you, Dr.
Because
Vigo.
sometimes,
Thank you. Yes.
Okay, thanks.
Thank you, Dr. Hanley. Suite M. Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Dr. Knight, in your testimony, You spoke about BC's experience. You said that it's not enough to decriminalize. What should have been done before decriminalization?
I think there are two main components that were missing from Vancouver's attempt at decriminalization. One is the scale up of on-demand treatment. We heard that there's this myth that people who want treatment have access to treatment, and in reality, there are often significant wait lists, significant barriers for people who actively want substance use treatment to get into treatment. So one thing is significant scale up of availability of evidence-based treatment prior to rollout of decriminalization. The other aspect is a element of dissuasion built into the policy, into the decrim policy. And that's what was done in Portugal, where there is actually, when somebody has substance use and is, they are required to go in front of a dissuasion panel who looks at their particular situation and their particular type of substance use and makes recommendations for what type of intervention they are going to get. So that was lacking from the rollout in Vancouver, where there wasn't that element of encouraging people to access treatment and trying to direct people with problematic substance use to treatment.
Est-ce que l'approvisionnement sécuritaire
Did safe supply save lives or not? And do you have any data on it?
The question around safe supply is complex. It is, so when I talk about safe supply, I want to be clear. There are lots of different definitions that have floated around in terms of safe supply. So I'm going to define safe supply in your question as prescribed safer supply, which is a prescription for a pharmaceutical opioid typically, although it can be other medications, to decrease somebody's reliance on the toxic drug supply, on the illicit toxic drug supply. We know from some of the research and some of the evidence that there are individual benefits from safer supply. We also know that there are significant concerns from the community and from some providers and prescribers around the potential public health harms. The reality is I don't think we're at a place where we have a strong enough evidence base to say that safer supply is good or bad. It is something that probably does need more evaluation and more research before we talk about whether it's going to be a key component to this.
Thank you. Thank you. Mr. Johns, please, for 2.5 minutes.
Thank you. Dr. Vigo, can you speak about the assertive community treatment teams? I understand that they provide wraparound care and treatment for people living in community with complex mental health or concurrent mental health and substance use disorders who might benefit from a supportive approach to care beyond that of standard services. Is this a model that you've looked at?
Thank you, MP Jones, for the question. That is absolutely, well, it's the only evidence-based community treatment for people with the most severe forms of mental and substance use disorders. It has been studied for decades. The continuum of care that assertive community treatment teams and its variation, flexible assertive community treatment teams, they have proven to reduce inpatient treatment, unnecessary inpatient treatment, to reduce ED visits, to improve the interactions between the patient and their families and their housing situation. So they are for sure an evidence-based approach to this problem. In fact, I am a psychiatrist in one of those teams in BC, and I'm the medical lead for the provincial assertive community treatment advanced practice. And we have evaluated this, and we have proven that it decreases to half the days of inpatient treatment comparing to the year before admission, and then continues the decrease up to 2/3 meaning that you only have 1/3 of the days as inpatient treatment in 5 years. And the same thing happens with ED visits. And the reason for that is that you have a wraparound team that seeks out the patient where they're at and makes a decision in the moment. Do they need to be admitted? Do they need to be discharged? Do they need to be under the Mental Health Act or extended leave? Or can they be decertified? So yes, it is an evidence-based, also cost-beneficial approach. We have proven that for every dollar invested in 5 years, you get $2.2 back. The government saves money through this. And there are 34 of those in BC. They are being expanded, and we need to do more, but that is certainly one of the evidence-based tools we need to rely on.
Do you consider the sort of community treatment teams a best practice that other jurisdictions should also implement?
Absolutely. It is the only practice, basically, for keeping these patients in the community without unnecessary certification, without unnecessary inpatient treatment.
Thank you, Mr. Johns. Next, Mr. Doherty, please, for 5 minutes.
Thank you, Mr. Chair. Thank you to our witnesses for being here. Dr. Vigo, you've just in your answer to our colleague Gord Johns, you stated some statistics and some facts. Are you able to table that document or that information with our committee, please?
Yes.
Thank you. Ms. Brett, in your opinion, does Canada prioritize recovery for those with substance use issues?
No, not at all. My son has lived through hell, gone through hell, as have I and my family. He's been essentially victimized by the lack of appropriate care. We've, pounded on every door, and yet in the end, his behavior became, he turned into an animal. I found him bent over, eyes closed, unaware that he had his eyes closed when speaking to me. And there was just never any supportive help, not what we needed when we needed it. It's chaos. It's malevolence to leave people to die on the street. It's malevolence. It's a form of evil. It's inhumanity. It's man's inhumanity to man. And we need to do everything we can to change this. We are in an emergency. There is no doubt. We must act as if this is a crisis of immense, horrific proportions.
You said that in your opening statement you've been in New West since 1994. I'm sure that over the course of those years, you've seen changes to our community and to the New West community due to the drug crisis.
Yes, there was chaos on the streets. It was reported by everyone. Violent acts. We had a carjacking. A taxi jacking, which resulted in multiple car crashes. In Vancouver, of course, we had someone who cut off the hand of an innocent bystander. The chaos has just continued to mount, and deaths continue to mount. We cannot, in good conscience, any one of us, continue the status quo. It cannot remain thus.
Would mandatory treatment have helped your son get clean? Has it helped get him clean? He's a year sober.
Yes, he is a year sober. He has been under the Mental Health Act involuntarily. This is the end of year 4. So it's been a process. He did use occasionally in that window prior to this last year. And but there has been such an amazing focus of care, limitation of movement, locked facilities were the ticket to begin with, and continue to be where needed and when needed. And he is a miracle of the benefits of mental health care, the best psychotic drugs like clozapine, great therapeutic services provided by the psychiatrists there. We couldn't be happier. This is a godsend. It's a miracle. We need more, and we need it now.
Ms. Brett, if you could speak directly to Prime Minister Trudeau, Health Minister Holland, and the Minister of Addictions, Minister Sachs, right now, what message would you give them?
Oh, dear God, do not prevent the opportunity for our children to have this care. They need it so desperately. They are dying every day, every minute. I'm so sorry. We need the floodgates to open. We need help. We can't live this way. Oh, we can't live this way. Thank you. Oh. Sorry.
I truly appreciate your heartfelt testimony, as you probably have heard. My brother's on the street as well too. Has been since the early '90s. Might even have. He started on the streets in Surrey and New West, and so very likely had probably been in the same circles as your son. So my heart goes out to you, and I wish you and your family nothing but the best. Thank you for your testimony.
Thank you, Mr. Doherty. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses. My first question is to Dr. Knight. Dr. Knight, you talked about the less resources on the difficulties providing addiction medication to those who are living in a rural and remote area. So you also recommended a universal coverage for first-line medication for substance use disorder, including naloxone. So what need to be done so they can have access to the medication, especially on remote areas and rural areas?
Thank you for your question. It's a very complex situation, and it really depends on the degree to which we're talking about rurality and remoteness. There are a large number of fly-in only communities in my province, and they often, almost exclusively, are communities that don't have pharmacies and don't have the ability to dispense medications within the communities. And so that is a major barrier to the use of medications that require either a pharmacist or a healthcare provider to witness and dispense those medications. The advent of the long-acting injectable buprenorphine has enhanced the ability to provide treatment for opioid use disorder in those communities because it doesn't require that daily use of medication. That is another area where the availability of long-acting injectable naltrexone, which I mentioned, would be useful in terms of providing another treatment option for people who either don't want to or can't go to the pharmacy regularly for medication options.
Thank you. My next question is to Dr. Vigo. Dr. Vigo, can you speak about the difference between a mental disorder and psychosis, and also if you can explain the holistic psychiatry care?
Thank you for the question, MP Sidhu. Psychosis is a syndrome that affects cognition. It entails, for example, delusions and hallucinations, and is very frequent in certain mental disorders such as schizophrenia or bipolar disorder type 1. So it is a syndrome as part of a disease. And the second question was what is holistic psychiatric treatment?
Holistic psychiatry care.
Yeah, right. So that refers to the BC Mental Health Act, which indicates that when someone requires involuntary treatment under Section 22 of the Mental Health Act, detention under Section 22, then that person can receive treatment under Section 31. That treatment needs to be psychiatric treatment. Now, for a while, there have been a lot of confusion and back and forth as to what does psychiatric treatment means and what can be provided under Section 31 of the Mental Health Act. And what I was indicating is that once someone meets criteria for the Mental Health Act, meaning they have a mental impairment that results in their inability to take care of themselves with physical and mental deterioration, risk to self and others, there is a treatment that could help them, but the person is unable to comply or engage with it, then you can provide the treatment as a psychiatrist under Section 31, and that treatment needs to be psychiatric treatment. Meaning that you cannot, for example, say this person has a psychotic syndrome because they have a brain tumor, then I'm going to indicate under Section 31 brain surgery. No, you need to provide things that are under the specialty of psychiatry. And that means any psychopharmacological approach, including, for example, a combination of antipsychotic medication and buprenorphine. And the distinction here is very buprenorphine or any other psychopharmacological approach that is within psychiatry and its subspecialty, such as addiction psychiatry. Now, the distinction is important because many of our patients with severe mental illness and substance use disorder do require a combination of these two and other medications and other psychotherapeutic approaches. So that is what I call holistic psychiatric treatment, something that can be provided voluntarily 99% of the time, involuntarily when needed, and that addresses the person as a whole.
Thank you.
Does that make sense?
Mr. Chair, do I have
No, that's your time. Thank you, Ms. Sidhu. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair, and thank you to the witnesses. Dr. Knight, I have a couple of questions for you, if I might. You talked about evidence-based treatment with respect to opioid use disorder, substance use disorder, et cetera. Can you tell us exactly where the so-called safe supply fits in that? What is the evidence? And if you have some, I think it's important that you table that with the committee.
Thanks for the question. There are some reasons why I deliberately didn't talk about prescribed safer supply in my recommendations, and that is partly because I feel in the reading of the evidence that it exists to date that we don't have a clear picture of the role of prescribed safer supply. I do want to highlight that it really is an intervention that is trying to decrease people's reliance on the illicit toxic drug supply, and that there are other mechanisms to do that as well that could be considered. Including what Dr. Vigo talked about in terms of that regulation of drug supply.
So Dr. Knight, if I hear you correctly, and this is your area of specialization, this is what you do, that realistically the use of, as you call it, prescribed safe supply, which I'm not entirely sure how much prescribing is going from some of the testimony we've heard, simply because there doesn't always appear to be a significant doctor-patient therapeutic relationship that exists. That being said, what I heard you say just now is the scientific evidence related to that is minimal. That would also go on then to consider that what we're seeing with this so-called safe supply is an experiment with a terribly vulnerable population. Is that what you see it as? I mean, yes, I agree that perhaps the intent was to save lives, but there's no evidence. And of course, you mentioned in one of your statements that it's important we use the best evidence there is.
I'd like to clarify that my position is not that there is no evidence for prescribed safer supply. My position is that there is conflicting evidence. We know that there are some benefits for people who access prescribed safer supply, and we know that there are some potential harms. And so what is not clear is where that balances out in terms of risks and harms. And anytime we do any intervention, that's the question: is the balance of benefits higher than the balance of harms?
So I'll just interrupt you there, Dr. Knight. And when you look at this, again, you talked about the evidence. I think it's important that the evidence that you cite, that you table it with the committee. Would you undertake to doing that, please?
Yes, I can send some evidence to the committee. Absolutely.
And again, I did talk a bit about this, as we've heard not just today, but multiple times from many witnesses, that this is an extremely vulnerable population. Would you agree to that?
I would agree that lots of people with substance use disorders have aspects of vulnerability. There are lots of people who have substance use disorders who are highly functioning people in our society as well. I go back to the idea that really people...
Sorry, Dr. Knight, I just have limited time. The other question I would say to you is does it make sense then, without their consent, to do experiments, first of all, on anybody, but certainly on vulnerable populations and people who may or may not be impaired by substance use?
I said this earlier in one of my comments. When we're doing scientific research, there are checks and balances in terms of the ethics and in terms of...
Dr. Knight, there was no checks and balances in so-called safe supply. Do you think that folks who were receiving so-called safe supply consented to it being an experiment?
I can't speak to the individual conversations between the prescribers and the people who receive safer supply, but it would be general medical practice to discuss the risks and benefits of any treatment with individuals.
Well, I think, Dr. Knight, we've established already that many folks who receive so-called safe supply didn't even have a doctor-patient relationship with their prescriber. So how could you possibly think that they have any consent to be part of an experiment? Please, I mean, as you're a scientist. I think this is basic science, is it not?
I think, again, we need to go back to the idea that this brings us back to the need for recommendations on a national level in terms of what are the requirements
but Dr. Knight,
for
this is
provision
about
of...
a basic science experiment gone wrong.
Thank you. That's your time, Dr. Ellis.
Thanks, sir.
Madame Brière, pour 5 minutes, s'il vous plaît.
Ms. Bruyère, 5 minutes. Thank you to all witnesses for being here with us today. Dr. Knight, I'd like to give you an opportunity to tell us more about the digital front door and the rapid access to digital medicine clinics.
Digital front door is something that we've rolled out in Manitoba relatively recently based on the experience out of Ottawa on increasing accessibility of different avenues for getting connected with addiction medicine treatment, particularly for people who live in areas where they may not have physical access to an addiction clinic or who have other barriers to being able to access service. So it's really an alternative door through either a computer or a smartphone to be able to essentially get the same access to rapid access to addiction medicine services as if you physically walk through our door.
Et quels sont les résultats? Est-ce que...
And what are the results? Has it given positive outcomes?
So far, it is still relatively new for us. We're still trying to figure out the right way to roll it out and access the people who most need the access to care. We certainly have had positive experiences in terms of people being able to access care that they wouldn't otherwise have gotten. And one of the ways that we're using the digital front door actually is to be able to provide initial contact for people in those remote communities that I spoke about earlier. Where otherwise people would have to physically get on a plane, fly to a community, and then come in through our walk-in clinics. So making that first connection and being able to provide some of the education and some of the initial assessment to make a plan for that person before they have to leave their community and come into an urban center has been really, really helpful.
Est-ce que ce serait quelque chose qu'on pourrait...
Would this be something that we could reproduce elsewhere?
Yeah, I think it is something that can be produced elsewhere. As I mentioned, we actually took it from the Royal here in Ottawa and adapted it to Manitoba, so it's already been taken from one place and replicated elsewhere. I do think that I mentioned this when we were talking about the VODP as well, there are some inherent problems with virtual care alone because lots of people who require access to care don't have computers, don't have smartphones, aren't able to come in through those routes. So having accessibility of low barrier in-person service is also really important. We can't do one without the other, but having a broad amount of doors that people can get into makes sense.
Tout au cours de cette étude,
Throughout the study, which has carried on for a number of meetings now, we've heard witnesses saying that the overdose crisis was largely due to the toxicity of the drugs themselves.
par contre, le ministre...
However, the Alberta Minister of Mental Health and Addiction said that the crisis was not linked with increasingly toxic drugs, but was rather an addiction problem. He said that it always ended in one of two ways, either in pain, misery, and death, or treatment. I'd like to hear your comments on that.
Thank you for the question. I prefaced my statement today by saying that my recommendations were going to be specifically for impacting people who have a substance use disorder. The reason I preface that is that while a lot of the people who are impacted by the opioid epidemic and toxic drug crisis have substance use disorders, not all of them are. There is a component that the toxic drug supply is sometimes killing people who don't have substance use disorders because it is toxic and because they don't have access to a regulated supply like we do with alcohol or other regulated substances. The reality is that our liquor stores are a place to access safe and regulated drugs, and our bars and restaurants are supervised consumption spaces.
Thank you, Dr. Knight. Suite M. Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. The answer to my question earlier was that a safe supply has saved lives, does save lives. A witness appeared. He had a clinic that provided care, and he said that we needed to move towards substances that have an extended effect, an extended release effect. I'd like to know what you think about that. Are there such substances? And if so, is there a difference between being required to receive a daily dose rather than a substitute product or a derivative that might act over an entire month? Dr. Knight, and then perhaps Dr. Vigo. 2.5 minutes.
So I believe your question is around the difference or the benefits or potential benefits around a long-acting agent like an injectable agent versus a daily dispensed medication, correct? I think one of the keys, so there is evidence for daily use of OAT medications like buprenorphine, like methadone. There is also evidence for those long-acting agents like injectable buprenorphine that is a monthly injectable formulation. For some people, getting away from taking a medication every day and having that routine as part of their daily experience is beneficial in terms of being able to get away from that idea of continuously taking a medication where they still have access to that medication in their bodies physiologically, but it's not always front of mind. And so we have evidence for both, and I think it's important that we have accessibility of a variety of treatment options for people who want to access them so that we can tailor treatment to the individual in front of us.
Et la disponibilité dépend de quoi? Des coûts?
What does availability depend on? Cost?
So the cost is very dependent on where people live and what their availability of drug coverage is, which is why one of our recommendations is broad coverage of these first-line medications for opioid agonist therapy. In my province, buprenorphine, naloxone, and methadone as daily options, as well as the injectable buprenorphine, are covered if people are on social assistance or if they have coverage through treaty status, but otherwise people have to pay for them, and they are relatively similar in terms of costs.
Thank you, Dr. Knight. Next, Mr. Johns, please, for 2.5 minutes.
Thank you, Mr. Chair. Dr. Vigo talked about the closure of Riverview in British Columbia, and Ms. Brett, you also highlighted that as well. We've lost beds, and we see provinces and territories scrambling to scale up to meet the crisis. But the federal government spent less than 1% responding to this crisis. Now, Ms. Brett, you talked about stigma not being an issue, but do you not believe that the federal government, it is stigma that they've spent only 1% responding to this crisis than they have COVID-19, and how important it is that the federal government scale up detox beds and treatment beds like you highlighted?
Thank you for the question. I'm thrilled to be able to say over and over again to all of you in significant powers of position and to the Prime Minister himself, we absolutely need to shift our approach to crisis emergency management. And in this case, and my son is a witness, he's evidence now that this involuntary care will work. Dr. Vigo has articulated a way forward, and without more beds, without more effort to create spaces, we can't treat these people. We can't take them off the dangerous streets. We can't save them. So absolutely, yes, we need the Prime Minister to move. We need the federal government to move now and quickly. Lives depend on it every single day. There's someone else, many who die. We need to act like every life matters.
Thank you so much, Ms. Brett. Now, the BC Liberals closed that facility, and we know that Dr. Vigo, involuntary treatment, it's not an ideal approach, but rather one that has been seen as a last resort. Dr. Vigo, what do you think can be done upstream to potentially avoid getting to the point where caregivers or medical professionals are pursuing involuntary options to keep people safe? And are there prevention or early prevention initiatives that are effective that need to be scaled up?
Thanks for that question, MP Jones. For sure, we need to implement the scale-up of voluntary options that would allow us to use involuntary as last resource, as you said. We also need, as Professor Knight indicated, broad access to available drugs such as buprenorphine and others, simplified ways of prescribing that. There's no buprenorphine. That's another important thing. Some of the drugs we use to treat these very difficult disorders have all sorts of adverse events and unintended effects. Buprenorphine has a very benign profile of side effects, and there are immense benefits, at least for people who also have mental disorders, to the depot formulations. I guess what I'm saying is we should simplify the way that physicians can prescribe buprenorphine and other alternatives, for sure, across the board. And second, if we could make, as a result of these conversations, depot naltrexone available across Canada, that would be phenomenal. And it's not there just because of a combination of bureaucracy and poor business decision-making that is fixable in the context of a public health emergency.
Thank you. Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. Dr. Vigo, I appreciate that you've also now shared your concerns about the fact that Health Canada's bureaucracy has stood in the way of access to an evidence-based drug, which is injectable naltrexone. Can you describe why this is important that Health Canada finally acts to make this drug available?
Well, we have a lot of safeguards that our institutions create to make sure that we have thorough evaluation and assessment of the different options. Now, in a public health emergency, we need to do a reassessment of those risk and benefit equation. And in the case of depot naltrexone, so this is a molecule that would block opioid receptors and would allow us to treat, for example, as we were discussing before, people who do not have developed, let's say, an opioid use disorder, but are in the initial stages of that and being exposed systematically to overdoses, either by seeking them out or through the contamination of the supply, and who would benefit from, let's say, because they are young and their brains are developing, from blocking those receptors.
I appreciate that. So earlier at this committee, we had British Columbia's public health officer, Dr. Bonnie Henry, call for the legalization of hard drugs, and she actually produced a report a little bit later on that recommended government consider running or have privately run retail stores to sell drugs like heroin, cocaine, and meth. Do you believe that this is something that British Columbia should embark on?
So the current approach of the government, the Premier has been very clear. There will be no expansion of those initiatives that make drugs available. The expansions are going to be for services that are within the context of treatment. So the access to opioids in the form of agonists, partial agonists, and antagonists will be through treatment centers, through recovery-oriented practices.
So we've also recently been seeing quite a number of drug busts of super labs, and the most recent one was found in your province of British Columbia. Are you seeing issues in regards to the increased availability of drugs as a result of the pilot project that made the possession of hard drugs like cocaine and meth and fentanyl legal to possess?
So the question is, if I had seen an increase, can you repeat that question?
In the availability of drugs on the streets in British Columbia as a direct result of the pilot project that made it legal for people to have fentanyl and use fentanyl in British Columbia.
Right. So the increase in availability of synthetic drugs is due to how easy it is to obtain those precursors. Those precursors come initially from China and now from Mexico, and they allow for, as I said, the backyard production of those products at scale. So that is the cause, and of course the responsibility falls upon the authorities to prevent the circulation of those precursors and busting those labs, as you just said.
So do you think the federal government is doing enough to actually ban these precursors and find and dismantle these super labs?
Again, my area of expertise is mental health, public health, psychiatry, and I think the enforcement area is a fundamental one, but it's outside my area of expertise.
Okay, but you deal with people that have addictions, and I'm sure they share some of the information. So do you think that the government of Canada is doing enough to deal with the precursors that are coming into our country and allowing criminals to profit off the drug issue and make fentanyl?
So, to be clear, everything that could be done to prevent those precursors to be in Canada and available to drug traffickers and producers should be done. No expense should be saved, and no effort should be avoided, because that is ultimately what would allow us to curb this crisis.
Okay, Dr. Knight, what are your thoughts? Do you think the government is doing enough to ban precursors in the country?
The enforcement area is not my area of expertise, and I'm not going to comment on it.
Thank you, Dr. Knight. Thank you, Ms. Goodrich. Dr. Pawlowski, please, for 5 minutes.
We're trying to come up with recommendations out of this committee, and with that in mind, I think certainly one of the things we want to do is decrease the number of deaths due to overdose, try to help people get their lives back on track. But I would suggest one of the things that I'm thinking of and coming up with recommendations is how do we address the deteriorating situation we see in so many downtown cores where you have increased numbers of homeless people, people with clearly psychiatric problems, substance abuse problems. How much do you think, and I'm both Dr. Knight and Dr. Vigo, how much do you think we would benefit from having more ACT teams, psychiatrists who then could assess and where appropriate, put people on long-term antipsychotics if necessary? Is that part of the equation? What we ought to be doing is trying to gear up those services and trying to address the mental health issues we see on the street. Dr. Knight and then Dr. Vigo, if you could make it quick, because I got a couple other questions too.
Sure, I'll try and make it as quick as possible. I think the ACT teams make a lot of sense. Dr. Vigo has talked about them, and I saw great work from them when I was in Vancouver. I do think it's important to also highlight that we're often talking about kind of downstream severe treatment, and we do need to think about prevention and early intervention as well.
Dr. Vigo, quickly.
Yeah, so my answer is a categorical yes. We need to expand ACT teams, and we also need to expand beds, again, long-term psychiatric rehabilitation beds, and we need to expand housing options for folks who require intensive services. So that continuum of care, the ACT teams, the inpatient beds, and the approved homes.
Okay, so that's a perfect segue where I want to go next. So how much of the answer is just more supportive housing? And you mentioned the closure of Riverview as being contributing to the number of people living on the streets. Like, should we also be contemplating reopening some long-term psychiatric institutions? I know supportive housing is probably better, but when you have large numbers of people with similar kind of problems, how about considering, or should we be thinking about opening more long-term psychiatric beds for people? Because I know, for example, in Thunder Bay, we closed down those long-term hospitals with the advent of long-acting antipsychotics. So, Dr. Vigo, you mentioned it first, and then maybe quickly, Dr. Knight.
So the answer is another categorical yes. Yes, we need to open decentralized units with long-term psychiatric rehabilitation beds, and we need to also have them in a continuum of care with housing. And this is not like rocket science. I mean, that's the same thing that happened in the UK. In the UK, they closed all the psychiatric hospitals, the old hospitals, and now they've reopened a whole bunch of decentralized units that exist throughout the country and have created thousands of beds, which is what we need.
Knight, on the same issue.
I don't have anything additional to add to Dr. Vigo's comments.
Okay, the last question is on involuntary treatment. Okay, somebody has an underlying mental health disorder, and under the Mental Health Acts, they qualify for involuntary treatment. How about, though, when somebody, and I don't know how often this happens, has a pure substance use problem? They don't have underlying psychiatric problems, but they are using drugs in such a way that they are clearly either trying to harm themselves or indifferent to harming themselves. Is there scope for, and should we be using existing psychiatric legislation, which I, a long-time emerged doctor as well, when somebody was suicidal, you have a duty to bring them into the hospital to try to prevent them helping themselves. Should we be using that existing psychiatric law on people who are abusing drugs and either actively trying to kill themselves or indifferent to their deaths? Maybe Dr. Knight to begin with.
Thanks. This is an ongoing debate amongst healthcare providers for sure. In my view, substance use disorder is a mental disorder. It's classified under the DSM-5, and for somebody who does have severe disease and is incapable of making treatment decisions, I would argue that our mental health acts would cover that. They are not being applied in that way, and so there needs to be conversation around that. And we do know also, again, when we talk about involuntary treatment, the only way to use involuntary treatment appropriately is if we have access to voluntary treatment for people who want treatment.
Thank you, Dr. Knight. Thank you, Dr. Pawlowski. Next up, Dr. Ellis for 5 minutes.
Would be for Dr. Vigo and Dr. Knight and for Ms. Brett, if we have a bit of time at the end. Specifically, and my colleague talked a little bit about prevention, and it's certainly something that's incredibly difficult and not talked about very much. But Dr. Knight, maybe in a few minutes, if you could give us your thoughts on prevention of substance use disorder and difficulties, which realistically we are not spending any money on at all in this country.
Yeah. I thank you for bringing it up. It's something that we often are focusing on the downstream effects in the people with very severe disease. There are some evidence-based prevention tools out there, and other jurisdictions that we can look at, and we've outlined some of them in our CSAM policy brief that we've submitted. Really, a lot of it comes down to supporting the fundamental social determinants of health: access to safe housing, access to activities and education, and supporting the growth of people, and young people in particular, who are able to develop in a positive way and not rely on the use of substances early on in their lives and develop substance use disorders later.
Thanks very much for that, Dr. Knight. And Dr. Vigo, do you have any comments you might want to add to that?
Absolutely. We have evidence-based interventions that we could deploy in every school in Canada for a relatively inexpensive investment. Developed here in Canada, by the way. The preventary intervention is one example. It has shown that when you intervene early enough in ways that can be delivered in 1 or 2 sessions in a school, that has effects many years after that in the decrease of risk of substance use. And this could be implemented, that should be implemented, because as everyone said here, our best bang for the buck is in preventing the damage to those children's brains.
Thanks very much, Dr. Vigo. And Ms. Brett, if I might ask you a couple of questions. Obviously, we're talking a bit about prevention now. One of the contentions we've heard is that nobody is born who wishes to become addicted to drugs as they age. Would you echo those comments? And maybe if you could give a comment with respect to what you think the benefit of treatment might be for younger children.
Thank you. Yes, Jordan has never seen himself as an addict. He was a football star. He was an amazing athlete on many fronts. He was also using drugs quite early, at age 14, pot, alcohol, and it was known to the school system that this was the case, and they placed him in a special after-school program, which he aged out of, which now, when he looks back, he claims that was an effective way for him to manage the impulses that he was feeling at that age. And so it's such a shame that there was no alternative and continuing program. For him, treatment with 26 treatment engagements and most failing. I mean, we were perplexed beyond belief, but the fact that those treatment centers existed was a reprieve from the street for him in a way, potentially saved his life. It helped him to accrue clean time. So we, we were really grateful for what existed at the time when he needed it. But he was undiagnosed with a severe mental illness in spite of engaging with mental health routinely. And so this is and a crime in itself. I'm not saying it's a crime. It's just a sad reality of inefficient resources applied to him. I'm not sure if I've answered your question.
No, that's great, Ms. Brett. I appreciate that. We've got about half a minute left. What advice would you give to other parents who are going and families who are going through what you have with your son, Jordan? What advice to the Canadians out there listening would you give?
Don't abandon your children. There is always hope. When it's the bleakest, when it's the darkest, go alongside them, walk in their shoes, walk beside them, see what they see, know what they know, and bring them into whatever facility and support that there can be, where there's dialogue, where there's a counselor, where there's someone who can become a listening post, who can generate whatever resources there are available. It's the only way. We have to pound on the door of the services available to us and bring our kids with us. Don't leave them behind. Join them in their misery, because you need to be witness to it. You need to speak when they can't. And in my case, Jordan was not able to describe in any real way, except to me privately, the terror of what he was experiencing. He couldn't express it in public or in a counseling session of any kind. So we need to be there for them, and we can see them through to a better place. And along with the aid of doctors like Daniel Vigo and the change in our BC government's intentions here, it seems, although I have no evidence that there is going to be new and effective beds made available for involuntary care. But if that were to occur, there would be a significant change. And I just pray for that day. We need it. Our children are dying.
Thank you, Ms. Brett. Thank you, Dr. Ellis. Next, Dr. Hanley, please, for 5 minutes.
Dr. Knight, among the many misconceptions that are being promulgated by my Conservative colleagues are that this government or respected healthcare leaders like Dr. Bonnie Henry are pushing for, quote, legalization of hard drugs. And what I'm hearing from many experts such as yourself is advocacy for a safe, regulated supply of drugs, such as we see, as you described, with the post-prohibition approach to alcohol. So I wonder if you can help us distinguish between so-called legalization of hard drugs, which I've never seen in this country, versus access to a safe, regulated supply as an alternative to the rampant access to a toxic supply of drugs that is basically being supplied through organized crime networks.
I mean, maybe one of the easiest ways to talk about that is by giving the example, because we have access to a safe supply of alcohol through regulation. There are communities in Canada where alcohol is not allowed. And in those communities, often an unsafe supply of alcohol becomes what people are using. In terms of homebrew, in terms of super juice, things that have much higher risks of harms related to it because it's an unregulated supply of a generally regulated substance. And so when Dr. Bonnie Henry was talking about regulation, and Dr. Vigo has talked about this as well, that curve where the lowest amount of harms is from a regulated public health approach to supply of addictive substances.
So, very briefly, because I have a couple more questions for Dr. Vigo. But what in practice, what would that actually look like? Could you give me an example of how that would be applied?
So. It's hard to be brief about this because the complexities of it is why I didn't actually address it in my notes, is that if we looked at creating a regulated supply of addictive substances more broadly, we would need to look at it from with a strong lens of prevention as well, in terms of ensuring that we're not having too loose regulations that increases the risk of early use and increases availability. However, being able to supplant the illicit toxic drug supply with a regulated and more predictable supply would likely decrease harms related to the existing toxic drug supply.
Thank you. Dr. Vigo, a couple of questions for you while I have the remaining time. One is, you mentioned the role of clozapine, and I think you implied that is underused or perhaps not as available as it should be. This was also reflected in Ms. Brett's comments about how this helped her son. So I wonder if you could talk briefly on that drug and what we need to do to elevate its access.
Right. So our organizations, our institutions, our practices are usually the risk benefit in the use of certain drugs leads to very stringent prescription protocols. Clozapine is one of those drugs that requires, for example, weekly blood tests, venipuncture blood tests, in order to check the white blood cells, because there's a very infrequent side effect, which is neutropenia, the decrease of blood cells, of white blood cells. And if that goes undetected, some people can die. Now, of this folks that we're talking about, no one's going to die of neutropenia. No one's going to die of an undetected infection because of neutropenia. They're going to die of an overdose. And so for this subpopulation, the risk-benefit equation needs to change. We are restricting accessibility by demanding those venipunctures that they cannot comply with simply. And so what we did here is we developed a protocol by which we forgo the venipuncture, and we do the DIPS, the point of care testing that can be done very easily by the ACT teams as needed, and therefore we can expand availability of clozapine. And again, but that needs a willing bureaucracy, and I say bureaucracy in a positive sense, not in a negative sense, in the old sense of the way we organize our rules and our administration. So a willing bureaucracy can accept this adjusted risk-benefit equation. The College of BC, of Physicians and Surgeons of BC, has accepted this, and it is now approved and being rolled out.
Thank you, Dr. Vigo and Dr. Hanley. Suite M. Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Dr. Vigo, Dr. Knight. Last week, Ms. Briand-Charret of the Public Health Association of Quebec said that current solutions are no longer sufficient to meet the scope of volume of needs and bring down the crisis. We need to take action to prevent more avoidable deaths, broaden access to voluntary treatment, put a better focus on prevention, ensure regulated supply, and reduce the legal burden. Do you agree?
Dr. Vigo
Dr. Vigo and Dr. Knight.
Those were a number of different statements. I believe I agree with most of them. I would say, though, that for some substances, the proper level of availability could be none. Carfentanil is 10,000 more powerful than morphine. It has no use anywhere in any regulatory framework that I can foresee. Nitazines, fentanyl, those are drugs that it would be very difficult to find a suitable availability that is outside the medical system for the purposes of treatment and surgery, et cetera, et cetera. So that's the only one of those statements that I would qualify, in the sense that for sure we need to find a sweet spot of regulation, and that for some substances maybe not.
Essentially, I agree with those statements. I do agree with Dr. Vigo's qualification of finding the right regulation for a regulated supply of substances, but absolutely agree with increased access, absolutely agree with prevention, and decreasing the legal burden associated with substance use.
Okay. Mr. Johns will have the last round of questions for this panel, 2.5 minutes.
Dr. Vigo, my question to you is, what can the federal government do to support provinces and territories that are trying to scale up mental health and substance use supports? And do you think the government should set a target for spending on mental health and substance use health that reflects the disease burden? We know many OECD countries spend significantly more than Canada on their healthcare budgets. In fact, it's double. Maybe you could speak to that.
Thanks for that question, MP Jones. I definitely think that in a country such as Canada, where the funding for healthcare is public funding, and it's a combination of meeting federal regulations and targets and provincial decision making, I think the federal government could.
Excusez-moi, Monsieur le Président, j'ai pas de traduction.
Sorry.
Apologies, Chair, I don't have interpretation.
A problem with translation? Okay, we're back. Please continue, sir.
Okay, so I was saying that for sure the federal government would have a role in developing incentives for provinces to prioritize evidence-based interventions that expand treatment. There will be innovations that need to be developed in the same way that in the UK there were innovations to suddenly scale up thousands of beds. Where the capital funding will come from, where the operating funds will come from, that will require important changes in the way we do things. The other thing, in our, again, with the utmost respect, bureaucracies, we sometimes find that to create 20 beds with one secure room, we have a timeline of 9 months. That cannot happen. And so we need to streamline our expectations with building permits, with community consultations, with things like that, so that we can actually expand those beds.
One last quick question. What can be done to reduce the risk of relapse following involuntary treatment, and what wraparound supports are necessary after treatment?
But that is an interesting thing, because it's only if the involuntary treatment is inappropriate that someone would have increased risk of overdose or death afterwards. Is involuntary care and the Section 31st of someone that has a substance use disorder, an opioid use disorder, would never withhold opioid agonist therapy. On the contrary, it would provide it in the form of, for example, depot buprenorphine that would ensure that that person does not have an overdose that will kill them.
Thank you, Dr. Vigo, Mr. Johns, and thanks to all of our witnesses. Ms. Brett, your testimony was extremely personal and extremely powerful. We wish you and Jordan every success on your journey to recovery. To Dr. Vigo and Dr. Knight, your presentations showed great patience, professionalism, and expertise, and we are grateful for that. Thank you all for being with us. Is it the will of the committee to adjourn the meeting? Yes, sir. We're adjourned. Thank you.